Cool. Okay, guys. So if this is your first time to one of our PhysioU webinars, welcome. I'm glad you guys could make it. What we do in these webinars are we try to use a combination of the PhysioU app as well as kind of this PowerPoint on current evidence, and really trying to say how can we make this more clinical based, right? There's all this evidence out there that people find that is great in a research lab, and our kind of what I enjoy is saying, hey, you know, I don't work in a research lab, I work in the clinic, I work in a university. How do I take that information and really try to kind of make it more manageable and easier to understand in the clinic and use it on Monday? So that's kind of what we'll do today. The topic today is all about like ACL. And as you guys probably know, ACL is huge, right? There's week-long classes, 40 hours on ACL rehab. So we tried to make a little bit more of a smaller niche because the goal is to be kind of done within an hour to an hour and 15 minutes. And so really it's just going to be the latest phase, right? Phase 4, phase 5, depending on which protocol you use for our mostly return to sports, right? All right. So when we think about ACL, there's two guidelines that kind of fit into this category, right? One of them is just your coordination impairments, and that's your ligament sprain. So this is the people that don't necessarily go on and have surgery yet. These are the people that have a ligament sprain, whether it's ACL, MCL, LCL, PCL. And how do you treat them as more of a coper? They don't actually have a guidelines for post-op reconstruction. The other guideline they have that's from 2018 is, again, an exercise-based for prevention. So again, this is pre-tear your ACL. How do we help people not tear it in the first place? So they don't have a guideline for ACL reconstruction protocol, right? So I'll throw that out there, right? Let's see. So if we go to the PhysioU app, right? Clinical pattern recognition, go to the knee, right? Right. So normally when I do this, we always have a diagnosis that's maybe not necessarily surgical based. So we're kind of having to work through this differential diagnosis. If you're having a patient that's coming in for post-op ACL, you kind of know the diagnosis, right? How many special tests do we have to do to confirm the diagnosis? None, right? It says it there in the big report. They're big, brace, swollen, wrapped up. We kind of already know that. So it takes away half of kind of my presentation for that. We can still talk about it as a sprain, right? So, but again, if we spend all of our time talking about how do people hurt it in the early stages, we would never get to the later stages. Okay, so we're going to kind of skip over some of this stuff and kind of go into our physical exam and associated impairments. All right, so again, I'll be bouncing back and forth. So again, we'll be following months, kind of the last phases, phases 4 and phase 5, which is our return to sport, more higher level. Right? Why do you think we want to focus on that? Like, what are some things, or what are some reasons why you think it's such a kind of hot topic or important to talk about? And feel free, either you guys can say it out loud, you can throw it in the chat, and then Cameron and Chris kind of will help manage the chat for me. Thanks, guys.
Safe return to sport.
Yeah, safe return to sport. Okay. Why do you think it's important to have a safe return to sport? Why do you think it's important to look at research and say, how can we be better at helping people return to sport?
We also receive re-injury rates are pretty common, and Christopher says no risk of re-tear.
Exactly. I would say there's never going to be a no risk of re-tear, right? The second you walk out there, there's always a risk, but how can we decrease the risk, right? I would agree. So, and that's kind of the unfortunate thing is, right? In the study, they looked at people and they followed them for a year up to 5 years, and a quarter of people retore their ACL, right? Girls, a third of them tore it in that leg or in the contralateral leg. So if you're female, especially between the ages of like 16 to 22 or 23, I think, all right, if you tear one of your ACLs, 1 out of 3 is going to re-tear that leg or the other leg. It's unfortunate. In my ACL class now that I run where I work, I have 2 girls, both high school females, or both high school athletes that are both going through it for the second time. They retore it. One made it 1.5 years. The other one made it, I think, 11 months, and then they retore. One of them, it's the same knee that she tore. That's the one that's been out 2 years. The other one was the opposite knee. So it's out there. The other thing is girls are 15 times greater risk for knee injury than controls after their first year. So again, just means once you tear it once, you're a high risk. And then again, that nice thing is that number goes down in the second year, but still it's pretty high compared to people that haven't torn their ACL. So can we be better, right? Can we send people out onto the field with lower risks to re-tear? And I would think as a rehab specialist, as a PT, wouldn't it be nice to say, hey, you went through a year of PT, you should be a lower risk to re-tear than controls. That'd be nice to say that, right? How many controls out there know how to squat and not let their knee dive in, squat without letting their trunk fall over the side? You think about, they didn't get a year's worth of training. So I feel like it's important to look at this stuff, right? So from that study, they kind of were able to identify 4 main asymmetries between the control group and these ACL groups on why they re-tear. So they followed them for 5 years. The people that re-tore, they kind of took them back and like, what did we look at? Let's look at all your data and say, why did you re-tear? And it kind of comes down to these 4, right? So some of them are deficits in strength, so knee flexor strength. Some of them are postural controls, so just their trunk stability. And then the other 2 are more just coordination. So hip rotational control. So you think about femoral internal rotation or external rotation, and then frontal plane mechanics. So femoral adduction. So you think about if someone's knee is diving in, adduction, internal rotation, someone's trunk is leaning over, there's your postural deficits, and their leg isn't as strong as it used to be, they're a risk to re-tear. Right? So it'd be nice to kind of say, hey, can we knock those 4 out of there? And I'll repeat it, they should be better than the controls because they had someone telling them what to do every single week for hopefully 9 months to a year. All right. All right. So in another couple studies, they looked at it at 1-year follow-ups. 16 of the 63 sustained an ACL injury. If you waited 12 months, you did a little bit better, but still your risk of injury is 15 times greater than controls in this study. So again, you have one study that's saying it's this many times. That idea is there's lots of studies that support lots of re-tears. All right. At a 5-year follow-up, right, 17% for patients re-tore. If they were less than 18, right, 7%. So the older they are, the more likely they are to re-tear. Why do you think that is? Why do you think that people that are older have less re-tears than the younger group?
Jordan says less active.
Okay. Oops, sorry. Yep. So potentially, they would kind of fall into just less opportunities, right? If you're under 18, you have more people play high school sports than college sports. More people play college sports than pro sports. So the older you get, right, you kind of phase out a little bit. Also, even if you play sports after college, like intramurals and stuff, it's not necessarily as competitive. And you don't have practice 3 to 4 times a week, 5 times a week. So just the opportunity is much lower. That's good. There's another reason they found as well.
We also said less training as people get older, less impact sports, decreased VO2 max.
Okay. So again, I would say the less training means less opportunity, because technically if you train less, wouldn't you be more at risk to tear when you do go play, right? If the people that are training more often tend to be in better shape, have better control versus someone who's training less, right? VO2 max, maybe they're just not in as good a shape, so they don't exercise as much. So again, that kind of fits into less opportunities for re-tear. So if you think about possessions played, right? They always talk about that in football and basketball. How many possessions played, right? Much less when you're older than 25. There's one other one.
Adherence to HEP program.
So you mean like the older they are, the more compliant they are?
Yeah.
Okay, possibly. I would not argue that point at all when it comes to my 16-year-olds trying to do HEP. Yes, there's definitely, you need to incentivize them a lot.
We're also receiving sedentary lifestyle, prefrontal lobe development, skeletal.
Okay, boom, good. So the more sedentary would fit into, again, less opportunities, just less active. But you think about neuromuscular control, right? You think about the older we get, the more control our brain gets. You hear about this, just this clumsy, awkward phase for people when they're sometimes going through their teenage years. They're still growing, their muscles are still developing, right? By the time you're 25, right? By the time you're 21, a lot of times you're done growing, right? for the most part. Your brain is a little bit more developed. So your neuromuscular control is just better, right? You are a little bit more balanced. You're less clumsy. So just again, that helps with, if you think of those 4 things that make someone a re-risk, 3 of them are not related to strength. They're related to control and balance, right? So that's a big one. So less opportunity, but also just better neuromuscular control, right? Another big reason why looking at this is so important is not only the risk of re-tear, but also just the fact that, you know, if someone does tear their ACL, right, there's not really the greatest percentage of rate people going back to that same level, right? You think there are definitely people out there that go back to the level and then maybe even higher, right? And they do better, but we're definitely not, ACL is not like your Tommy John where people come out throwing faster, right? Right? Barely over half go back to that same level. So this study looked at, well, what are the reasons why? What are the reasons why people did not return to play at your RTP? So a big one is quad weakness, right? Another one is reduced, like this scoring scale, international, like a knee scale, and then elevated pain with fear of re-tear, right? So we think about, one of them is how confident are they in their knee? One of them is how fearful they are. And number 2 is just quad strength, right? So part of our rehab program should look at their ability to how fearful are they, how confident are they in their knee? Because if they go back to they're not going to go back to a sport if they're not confident in their knee in the clinic, right? So that should be another part. So if I kind of recap where we are, we need to make sure people are safe to return, so less risk of re-tear, but also we need to make sure they're confident to return, so they do go and return. Okay. So this kind of talks about those psychological things. And so 81% return to any sport, 65 prior level, 55 to competitive sports. Right? 20% of all patients actually stated that psychological factors were a primary reason that they did not return. So especially in your lower levels. Why do you think that there's more of this psychological factor in the lower level athletes and like a higher level athlete? Why do you think that people are more fearful to return to play if they're a lower level athlete?
Less training.
Less training. Yep. Okay.
David says they are less educated on the condition.
Okay. Possibly. And that would come down to our fault as PTs, right? Or rehab specialists or ATCs or whoever's working with them.
Motivation for returning to play and less confident in abilities.
Yeah. So the big one is motivation, right? The lower level athletes normally don't have a financial gain in getting back to their sport. It's more for quote on the words, like for love of the game, right? They're not going out there making money. They're not paying bills and putting a roof over their family's head, such as maybe a higher professional athlete. So there's definitely less incentive to return. And they might have this, oh, it's not worth it. So I'm a little bit more fearful because if I get hurt, I can't now go do my job as a bank teller and provide. So yeah, so good answer there, guys. All right, so what causes these poor outcomes, right? We know on some of the research it's talked about this quad weakness, right? There's a couple articles that talk about altered gait mechanics. So even years later, they still are not loading the knee the same. And this big one is this loading. So a lot of our return to play tests that we'll talk about later, a lot of them come onto the eye test of, are they loading the knee well, right? If someone's not confident in the knee or they don't have the strength in the muscles around the knee, they're going to load it differently. If the knee is loaded differently, you are a higher risk to re-tear, right? So that's going to be, and you're less likely to go back to sport. All right, so that's kind of what we want to talk about is this loaded stuff, right? So in this systematic review that took 18 different studies, 14 of them used quadriceps strength and kind of stated that there was a 15% deficit at the 6-month mark. And these were all people that were set to return to sport. So they were discharged at return to sport, right? What problem do you guys have with that? If you have a problem with that. What do you guys think? So I'm returning this person to sport at 6 months. right? They passed the sports test, the hop test, this, that, but they had greater than 15%. They had a greater than 15% quad deficit on their 1 rep max. You guys have any issues with that?
Shows instability in the knee.
Okay.
They're compensating for the test. Muscle imbalances leading to additional injuries.
Good. Okay. So that question was kind of a test of your current knowledge about ACL return to play, because at 6 months, right, that's really early. Even if you are a stud, right, your graft isn't ready at 6 months. Even if you pass everything and you return at 6 months, which professional athletes do, there are a few high-level soccer players that go back and they do fine and they don't re-tear, but your graft itself isn't strong enough at 6 months, and we'll talk about the thing. So that's one issue. Number two, yeah, a lot of the cutoffs are this 90%. You should be at least 90% of the strength compared to the other leg. So if they're greater than 15% difference, that's a risk. So the unfortunate thing, though, is that people are being sent back to sport, but yet it's too early and they don't have the strength, right? So part of that is, again, on the rehab, but what drives that even more? What do you guys think drives a patient being discharged from PT?
Run out of visits.
Yeah, so it's unfortunately, it's driven by, it's not necessarily driven by the therapist at times. It's driven by, right, insurances and stuff like that. The other thing is at 6 months, right, patients really don't have any pain with anything, right? They're able to run, they're able to jump, they're able to climb their stairs, they're able to do everything. So again, your functional goals really probably have all been met at this point. So it's like, so again, we have to either start to look at that ahead of time and be like, all right, from months 4 to 6, I need to start saving a lot of these visits, because it's not necessarily safe enough to do cutting and pivoting and single limb hopping tons, but maybe at month 4. However, I need to work on things. Maybe we still continue to work on strength and stability, and then have them start coming back every other week or something. So I think that's a very specific situation to where you work at and what state you're in, and that's different. But one of the reasons this study stated that was they were discharged not necessarily because they felt everything was perfect. It was more of, hey, this is where we're at, return to sport, which is unfortunate. Another study looked at athletes that did return to sport, and the month prior to going out, right, a majority of them had greater than 10% deficit, and 31 of them had greater than 15% deficit. So again, just another story that shows that there's a big difference in their quad strength when they're going back to sport. Good. Okay, so that kind of just plays into, there's this big quad difference, right? This one talked about this gait mechanics. So in this article, which was 2 months later, or 2 years, 24 months later, 2 years later, they were looking at this decreased knee flexion, knee extensor moments during gait. So someone who had surgery 2 years ago, they're still not loading the knee normally compared to the other leg, right? They're not straightening it out all the way like it should. They're not loading it as it should, meaning if they're going to go run around and jump on it and they can't even walk normal, that's kind of a problem, right? What do you think the issue is with that part of it, right? Anybody have comments about kind of this loading factor with walking?
Increased stress on the other leg, more
Yep.
injury and pain, and Anthony says creates other imbalances.
It does, yeah. You start to create compensations. Definitely agree. If you're walking on a knee and you don't get to full extension every time, you've kind of lost some of your shock absorption, right? You need your knee to go straight. So then when you load it, it bends a little bit, right? And that bending absorbs shock. It's like catching that egg, catching that water balloon. So if you never get to full extension, then you're having a shorter runway, right? I have a mentor that always talks about landing a plane, right? You're landing a plane on a shorter runway, meaning there's more stresses on there. So however, one of the issues though is they were able to identify this in the lab, right? So there's lots of people that at 2 years out, they're walking. We can't see it just with the naked eye, right? Hey, it looks good to me. It looks like it's straight. They feel like it feels great. But if you put them in a laboratory setting, you start to see these differences. So I think that's kind of an issue because we don't necessarily, not everybody has access to the laboratories, but yet the tools that we do have, our eyes and our phones, we don't necessarily see it. So we kind of have to take the word for it and say, hey, it's an issue. We should work on it. However, we may not be able to actually see it. If we continue along this asymmetry route and loading, right, 6 to 9 months post-op on a bilateral drop, so they jump off of a step to land. These were people who were cleared to return to sport. So they were saying, hey, you are good to go, right? Go back to anything you want. And you see this big difference in asymmetry. So the controls, right, the one leg they chose was almost 100% compared to the other leg versus your ACL population, right? They're only at 85% loading compared to the other leg, right? And so we can say, all right, 6 to 9 months, still got some work to do. Here, over 2 years later, right, they're still not necessarily as equal compared to the involved. It's closer, but there's still a difference 2 years later. Another study looked at squats. So instead of jumping, let's find something less stressful, right? Maybe it was just they were fearful of landing, and that's why they had this compensation. But here, they found just with a squat at someone who's over a year out, the controls were pretty equal versus the ACL group. There's a 17% reduction in the loading. Right? The interesting is there's no difference in quad strength. Right? So what do you think is the reason? If they have the strength, right, they have the strength, why are they not loading it equally to the other side?
Fear avoidance, range of motion.
Yeah. So possibly fear, right? They don't want to load it. Maybe they don't have range of motion. I would hope by 13 months that they have range of motion enough to do that type of squat. Maybe they can't get their butt to their heels, right? End range, but I'd hope they could at least get past 90.
Psychological.
Yeah. Another thing could be definitely, maybe they don't even know that they're not loading it, right? In a follow-up to this, they had patients fill out how they felt they were loading. And majority of the people that were out this far felt that they were even. Right? They're like, hey, I feel great. I'm 50-50. They squat down and there's this reduction. There's this different side to side. So they may not even know it. Their body has just learned to say, hey, this is just the new me. This is how I load it. So again, our job is to take that away from them or to train them out of it, right? I think in that other study at Philip, they said that really same thing with the walking extension. We are good at telling people that are 60 to 40. So if there's a 20% difference in their loading, like if they do a squat, we can tell, right? Patients tell. Anything less than that, anything less than 20% difference in loading, you weren't able to tell with the naked eye. So again, this would be your laboratory setting or a force plate or something to be able to tell the difference because it may look great. They're just not loading that leg as much. So if that's the case, how do you train that person? Right? Anybody have any ideas?
Single limb all across the board.
Awesome. Awesome. Yeah. All right. So I would tell the patient, all right, so you're using your opposite leg a lot more than this one. It doesn't hurt you. You have the strength. You're just not using it. We're going to get rid of your other leg then. You're going to do everything on that one leg. Right? And the nice thing is that's a big part of ACL rehab. Right. Right. So that was kind of this intro to why are we even going to look at return to play? Why is it worth your guys' Tuesday night after a week of class or work or rotation or whatever to sit down with me for an hour? That was hopefully a reason why, right? People don't load it well. People don't have the strength. People re-tear. People don't go back to sport, but yet they're being discharged. So can we clean that up a little bit, have better outcomes, and what are the tools we have? What does the evidence say to do it? All right, so if I go back to here, right? So if we look at associated impairments, right? So again, we are kind of under this ACL or ligament sprain kind of idea, right? A lot of the things we want to look at are swelling, right? What tests do you guys like to use for swelling, or what are common tests for swelling? Especially ones that used, if you know the one used in research a lot for post-op ACL.
Girth measurements via tape measure.
Good. So girth measurements is one because it's measurable, right? And there's another one. Think of something that's measurable.
Range of motion.
Range of motion, possibly. Range of motion would be more of the outcome because of the swelling, right? If someone has a more swelling in the knee, it will not flex as much, right? Think of one other one, right?
Sweep test.
Yeah, sweep test or stroke test, right? So the idea is like you can measure that. And I'd say the reason why I like girth, the one you guys said, as well as the stroke test or sweep test, is because I can teach a patient to do that, right? So often if we're working on jumping and high level stuff, their knee might have a little bit of swelling afterwards. And that's kind of part of the process. It's me educating them that, hey, you know what? You're doing this stuff that's stressful to your knee, right? A lot of this is beneficial for your knee long-term, but in the moment, there are some negative effects to this. We are loading your joint, we're loading things, you're loading your tendon. So it may swell. However, when you go home and you're gonna redo this program on your own in 2 days, we wanna make sure that you're not still more swollen than when you started. So I teach them like, hey, right now you're at a 1+ on your stroke and your girth is whatever it is. I want you to take that before you do your stuff. And if you know what, if it's higher than what it was right now, wait another day, right? So I kind of teach patients to be their own guide on how hard do I push it, right? So it's important. Okay, good. If we talk about strength, so one is edema. Let's look at it, right? Strength. What are some of the strength tests we want to look at based on the risk factors for re-tear?
Amanda Lee said quad strength.
Good. Quad strength.
Also received abduction and adduction strength and glute med strength.
Good. 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 Can you guys think of? Oh, good.
Hamstring strength by David.
Yep. Hamstring strength. Right. It helps flex the knee. Think of. Can we get 2 more in there?
We received some functional tests: single limb squat and single hop test.
Perfect. Okay. So those are great ways to look functionally at how do they use their strength. Think of just muscles. What muscles would you want to, what other muscles would you want to look at?
Gastroc strength.
Awesome. So plantar flexor strength, right? You need that for running. You need that for jumping, right? Think about more transverse plane.
Core strength.
Okay. So yeah, definitely we can look at, like, there's some studies that talk about side plank strength, but I was thinking more like just hip external rotators. I know you guys said glute med, glute max. So hip abduction, hip extension, both of those muscles are also rotators, but your deep hip rotators control femoral rotation, right? So great. So we want to look at this stuff. So we can look at, right, glute med, glute max. We can look at knee extension, knee flexion. When it comes to post-op ACL, right, hopefully we have the ability to pull out a handheld dynamometer, an electronic dynamometer, and use that, because that's what all the research says. That's what they base this on, about this 90%, right? There's milestones for return to running, milestones for return to hopping, milestones to return to play. And those tests are either used on isokinetic or this handheld electronic. All right, so here would be kind of like your isokinetic testing and your knee extension testing. Good. All right. Good. I think you guys knocked out some of the other ones, calf, core. All right. How about as far as balance, right? Balance should be something we look at. So either star excursion, right? Your Y balance test. And then you guys also talked about your hop testing, right? I think someone threw out the hop testing. Good. All right, so let's go back to this. Okay. So if we look at the current concepts for ACL reconstruction, so part of this is from Dreos PT. Another part of it is from University of Delaware, who does a lot of research on ACL reconstruction. Yeah, and so what they look at is, these are some of the big things we'll look at. So one is your balance proprioception, right? So if we're looking at the Y balance test, we're looking at their anterior direction, right? So are they able to get pretty close to the other side? We're also looking at composite score. So if they do posterior medial, posterior medial, posterior lateral, and anterior, and you add all those scores together, is it within 94% of their leg length, right? The nice thing is we want to be able to progress them from a stable surface to then unstable surfaces and even multitasking, right? Why is it important to work on multitasking? And what are some good examples of multitasking, do you guys think?
All sports require multitasking.
Yeah, all sports. You don't want someone thinking about their knee and their balance when they're chasing a ball or catching something or hitting something, right? Good. What else?
We have is ball toss and to get them to balance without thinking about their knee. And
Awesome.
a single limb squat, catching a ball and counting.
Good. So I heard catching a ball, great, makes it functional for their sport. So if they play frisbee, hopefully you're throwing them a frisbee. If they play rugby, hopefully it's a rugby. If it's tennis, it's a tennis. I mean, right? Idea, can you match their thing? And I'd say the nice thing about that is, one, you guys totally nailed it. It makes them not think about their knee, not only because it makes the balance harder, but also psychologically, it makes them stop thinking about their knee and actually think about something that they can do. So it builds confidence, right? And there's a great study that talked about just putting a ball in someone's hand in the first 2 weeks. So even if they're laying on the table doing NMES for their quads, but they're shooting a basketball in the air, right? That had better outcomes at 6 months in the Tampa scale, their kinesiophobia scale, just because it makes them more confident in like, hey, I can go back to sport. I can do this. Look, I get to play. You're not thinking about your knee every single second. So great answers with that. The other one I heard, I think, was counting. Yep. And that's great, right? So there's lots of studies that talk about having people count backwards, adding that second task really changes kind of your brain cells. So it means your neuromuscular control has to work a little bit harder, which, if we think about it, that's one of the risks for re-tear, right? So it may seem simple, but having them count backwards or having them count in a different language or something are great ways to train the neuromuscular part of it.
Do you also use perturbation on civil service?
Yep. Perturbation is another great one, right? And it can be, I'd say you would ramp that up where it's the perturbation they know is coming, so they can see you tapping them, they can see you touching the Bosu ball, and then it goes to they don't know it's coming, right? Where you're kind of all of a sudden from behind them, you're tapping them or you're kicking the Bosu ball on different sides, and they don't know which direction, so they have to they can't anticipate it, I guess. So ramp it up, right? Good. Okay, so that's a big part of early on, right? You should think by the fact when someone's able to stand on their knee, right, they should be working on their strength, their range, but pretty soon we want balance and proprioception, right? They did studies that did this like a speedy recovery where they started body weight exercises and single limb stance really early versus a group that did more stuff on the table, short arc quads, long arc quads, straight leg raises, and stuff like that. And the group that started more weight bearing sooner, right? They had more pain early on, right? So we might have to control it. But at 6 months out, they had better quad strength and they had scored higher in their outcome measures than the group that spent more time on the table. So depending on pain levels, we can definitely say, hey, can we do this more expedited loading program? Knowing that it hurts, we explain that to them, we tell them it's safe, but it gets them better. It gets them to where they want to be sooner. Okay, so return to running, right? Maybe I should have made this a question part, but now you know the answer. So if we're going to return to running, we want to make sure someone is safe to return to running, right? So there's these milestones that people have to meet, right? Ideally, you're not letting them return to running until 3 to 4 months, and that is based on what? What do you guys think? So this isn't return to running. This is when can I test them to return to running? When would it be? What's that?
David said the graft.
Okay, the graft. Good. So the graft. So I would say, is there one graft that you're more likely to return to running than the other? Sorry, Dave, I'm going to put you on the spot there, man. Because you are right.
I don't know if there's I think all the grafts you should be able to return to running. I know that the patellar tendon graft is a little bit stronger in terms of right off the bat. So I don't know if like you're able to progress that a little bit faster than the other ones. But eventually you should be able to return to running with all the grafts, right?
Totally. Yeah. You should be able to return to running with all of them. The idea is the people that are going to return at 3 months, right? Those are probably the people that have a hamstring graft because they don't have nearly as much pain in the front of their knee. They're able to load their knee a little bit better because they didn't have their patellar tendon, their quad, their extensor mechanism disrupted, right? So, but David hit it right on the head. Your hamstring graft's a lot weaker. It has twice as many re-tears as your patellar tendon graft. So they may feel like they can return to run. Like, man, I feel great. My knee's doing great. I'm killing it on the bike. I'm killing it on the elliptical with no pain. However, their graft itself is not as strong, right? Compared to your patellar tendon graft, which is actually stronger, but your mechanics aren't as good. Your strength isn't as good because you can't really push it as hard because your knee hurts. You have patellar tendonitis, you have patellofemoral pain. So that's definitely one that you may choose to speed up or slow down based on that. But the number one reason is really your surgeon, unfortunately. So your surgeon may have a protocol in place that says there is no running before 4 months, right? We have the place I work, right? We have lots of orthopedic surgeons, and even in this one orthopedic setting, they're not even on the same page, right? We have one guy who is very strict and very slow and says there's no running until 4 months. We have another guy that says they can run at 13 weeks, which is relatively the 3 months, if blah, 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 right? So we have one that's a little bit more conservative and one that's a little bit more free with it. So, however, before they run, these are the milestones they should meet. So quad strength, 70% of the uninvolved, right? No more than trace swelling. That would be the 1+ on your stroke. They can do 8 out of 10 single limb squats with good control to 45-degree angle, and they should have 95% range of motion. Of that 95% range of motion, what are you okay with being that 5% missing? Would you rather them have full extension and missing 5% flexion, or full flexion and missing 5% extension?
Missing some flexion.
Exactly. Yeah. Do we go to end range flexion when we run? No, right? There's people that run lacking 20 degrees of flexion, right? So we want to make sure they have full extension. Good. The 8 out of 10 single limb squats, it's because you're going to, every time you land, you're going to go into like a mini single limb squat, right? So we want to make sure they have good control. We want to make sure their knee hasn't really swelled a lot, and we want their quad strength to be 7%. So that 70% is your handheld dynamometer, right? Or the electronic one. If you don't have one of those in the clinic, what would be another way that you can identify 70% strength compared to the other side?
Manual muscle test.
Okay. So I'd say the problem with that is if I have someone who can do 100 pounds on the other side, right? I'm never going to be able to tell if that is 70 pounds, 80 pounds, 90 pounds, 100 pounds. Maybe they have 120, because your arm is not going to hold, right, more than a certain amount. So that's kind of, so if it's someone if it is your 85-year-old with knee OA and their max strength is only 40 pounds anyways, you can tell a difference, right? But to be able to tell 70% from someone who's kicking over at over 100 is really tough. So what else? What do most gyms or PT clinics have?
We have test 5-rep mats of uninvolved side or quad girth measurement.
Okay, good. So I like testing the 5-rep max or even the 3-rep max. And ideas you would use a knee extension machine, right? So everybody has kind of the knee extension machine in most gyms, and they call it the 1-inch lift. So it's not about can they get their knee fully straight. It's what can they lift the stack 1 inch. So it's just break the stack. So you put it at 100 pounds. Can they break it? Yep. Go to 120. Can they break it? And you kind of find where they start to really, really struggle and see if they can do 2 to 3 reps there. And then you do the same thing for the involved leg and look at the difference. Right. So they did a study that looked at leg press, knee extension machine, handheld electronic dynamometer, and that to compare it. And they said that the leg press at this 80-degree angle, so not up at like 45, but like they're sitting in the chairs at 80 degrees, was equivalent to using one of these other fancier, more expensive machines. Not 100%, but reliable enough. It's okay. Most clinics have that. Most gyms have that. That's good. So that would be our return to running.
Quick question
Okay.
with the
Yes.
handheld dynamometer. Is there
Yep.
research to that kind of standardizes the placement or how to best get a reliable result?
Yep. 5 centimeters above the medial malleolus, you put the band, you put the like a gait belt on, and you lock the knee at 90 degrees with the towel roll. They always use a towel roll to take it out, and then the electronic dynamometer. So when they kick out, it goes to about 80 degrees. So if they sit at the end of the table and just let their leg hang, that's where you kind of lock them in at.
Okay.
Right? Because ideally when it hangs, it would hang at 90.
Mm-hmm.
But knowing when they kick, they should kick out. There's going to be some give in the gait belt. There'll be some give on the machine. There'll be some give in the towel. But that's kind of how you would standardize it. Because I would agree, if I test someone's strength at 80 and I test it at 50 or 60, there's going to be a difference, right? One is more passively insufficient because it's bent more. One should be stronger.
Got it.
Good question. Was that yours, or are you taking credit for somebody else?
I'll take credit for that one.
Okay, good. All right, nice. Okay, so that's a return to running. So let's say they pass it, right? I run through those things. I check their quad strength, swelling. All right, so let's start running. Here is a running progression, whether it's a treadmill or a track, right? What is the reason to have this progression and this parameter? Why do you think it was created? Do you think it's to prevent re-tears?
To make sure we aren't progressing too quickly to set bad treatment.
Okay. What would happen if we progress too quickly?
Could be inflammation and pain that we would have to settle down before we could get back to where we were before that.
Perfect. And what do you think actually hurts? So if you're saying, oh, my knee hurts, right? What is it that hurts? You think it's the ACL graft that hurts? You think?
Could be the quadriceps tendon that's hurting because hasn't been used to that kind of stress in a long time. Possibly hamstrings if something's tight.
Okay. So the two most common complaints were patellar tendon and patellofemoral. So if someone who hasn't ran in 5 months, their strength is only 70% of the other side, they have some swelling already in the knee, they probably don't load it 100% normally, and then you're going to go out and run, right? You're going to get some stresses on your knee that are not going to be friendly. But again, part of it's okay. That's how you train it. But that's why we have this progression. So you gradually load the tissues. Because like you said, your patellar tendon hasn't been loaded that way in a while, right? Your patellofemoral joint hasn't been loaded. So those are the two most common. And then later on, it was, I think, Achilles tendonitis was the next one, right? You think about your Achilles hasn't ran probably like that in a while either. So good. Yeah. So we want to just make sure there's not necessarily a risk to re-tear their ACL. It's just a risk of inflaming everything. And now they can't run and they can't squat and they can't do their quad strengthening because their tendonitis is bothering them. Right. Good. All right. So that would be part one of our return to sport is hey, get these people ready to run, right? Early on, it's balance, proprioception, strength, range, right? Control swelling. Now we're running. Great. Now let's look at hop testing, right? I would say I wouldn't start running and hop testing on the same day, right? You guys can kind of guess why, but you can definitely start them around the same time, right? So we said that running can be 3 to 4 months, hopping around the same time. At 4 months, they can start hopping. However, their milestones are a little bit higher. So instead of quad strength of 70 for your running, now you have quad strength of 80. So they need to be a little bit stronger to jump. A fusion, trace, or less than trace, so 1+. Full knee range of motion, no pain with single limb hopping. So can they even hop on their leg without it hurting? And then again, that single limb squat form. So similar to the other side, or similar to the milestones before, right? So that'd be your milestone. So now, right, what are the hop tests you guys want to go over, right? If you're seeing this patient, let's say they're 4.5 months out, you've been running for 3 weeks, you're ready to start you want to start testing their hopping. What would be the test you'd want to look at?
Single leg hop test.
Okay, so single limb for distance. Good. What else? What are the ones most commonly used in research?
Triple hop.
Triple hop. Good. There's 2 of them. So single hop for distance, triple hop for distance.
Crossover hop.
Crossover hop for distance.
David also wanted to add for height.
Okay, so vertical. Yep. Vertical is not necessarily one that's tested early on to see where they are, but it's definitely one that's used for discharge for a measure of explosion and power.
6 meters top.
Exactly, yeah, 6 meters. So those 4, the single, the triple, the crossover, and the timed, are part of this cluster called the noise hop tests, right? So there's been lots and lots of studies on noise hop tests. When you first have them jump, right? Do you think you're really going to be able to do a timed hop, a triple hop? Probably not, right? So maybe on the first day, you're really just measuring single hop, right? Because that may be all they're comfortable doing. It's the first time they've hopped in 5 or 6 months. A lot of times they tore their ACL because they were either jumping or landing from a jump. So there's this extra fear going on with it. So you may just start with your single, right? But the cutoff, right, for return to sport, the cutoff is this greater than or equal to 90%, right? Meaning if I jump 4 feet on my right leg, my ACL is my left, I need to jump at least 3.8, whatever the math is. But it would be nice if it was equal, right? If I say we have this problem of a really high risk of people re-tearing once they go out to play sports, but we're discharging them at 90%, what would your logical answer be? What do you guys think? You have a 33% chance to re-tear your knee if you're a younger female within a year, and we're discharging you at 90%. What would be the logical answer? Would be make it 100%, right? So part of it is a lot of these studies are using 90% as the cutoff, which is kind of what there is a big drop off. If you're above 90 or below 90, there's a big drop off. However, they're not yet to 100%. So the easy thing would be is get them to 100%. All right. Okay. So soreness rules, right? Are you guys familiar with the soreness rules? All right. The idea though is that, and it kind of goes into what we talked about for swelling. When we start to jump and run and do exercises, we're going to cause soreness. We're going to cause swelling. That's normal, right? Ideally, our soreness would be in our muscles, right? Kind of like DOMS, right? Delayed onset muscle soreness. But sometimes it's in the knee. And again, that is totally okay, right? But it's a way to help patients understand how to advance things, but also for clinicians to make sure we're not progressing too quickly, but also maybe we're not doing enough. Maybe we can actually progress them more. So it's just saying that if you have soreness that doesn't go away with warm up, it stays the whole time, you may need to take a couple of days off and go down. That was too much, right? If soreness that goes away during warm up, right? Okay, maybe we need to stay where we're at. If it's soreness the day after, all right, just take a day off, but then stay where you're at. No soreness at all. All right, we got to advance our program, right? So we kind of want, so the ideal thing would be is we want patients to be sore for a day, right? Take that day off and then do it again because they don't want to advance. If you're sore for the day, stay right. Advance again with the idea then the next time you do it, there's no soreness. Great, we can advance, right? What are the ways we advance someone's program?
We had a quick question
Yep.
from Mr. Deekers himself. He asked, how are we programming from not just jumping into single leg hops?
Mm-hmm.
How are we programming it into progressing it from the very beginning to actually testing them? Are we going bilateral and then single lateral, or how are you doing that?
Yeah. So normally they're starting to hop by like 3 months. Hop meaning 2 legs. So jump, I guess we'll call it, not hop. So normally by 3 months, you're starting to work on stepping off of a step and just kind of catching it. Can they just load properly? It's all 2 legs. Can they explode off 2 legs? And they're doing little micro hops. You're really more working on just form, right? And so then for that whole month, you're kind of working on going from a level 2 to a level 3. So you add like risers onto how high they jump on. And we'll talk about a little later on with like some of the plyo stuff. But yeah, they're definitely working on 2-legged jumps before they get to a single leg jump, right? And then when you start on the single leg jump, ideally their first session is like, okay, 40 touches max, right? So you can do 40 single limb hops, right? They're probably only jumping, 8 feet, maybe a foot max. And they're just jumping, and they're really just working on when they load their knee, can they go into triple flexion? So can their ankle flex? Can their knee flex? can their hip flex, right? So when they land, can they do it? When they take off, can they go into triple extension, right? So you really work on that loading. So I may still test them because I want to see how confident they are when they jump from one to the other. But I tell them, hey, be safe. At Delaware, when they tested at like the 3-month mark, they have them put their brace back on when they test it for the first time, right? I don't necessarily do that, but I just tell them, don't jump as far as you can, jump what you feel comfortable. And a lot of times they jump very small and then the other leg to jump in feet. But it's just kind of to put it into perspective for them a little bit. And then they work on it. But that's a good question. But yes, definitely 2 legs come first.
Are you the first time you test them doing the hop testing? How strict are you on their landing and sticking? Are you holding exactly to the criteria given that it's the first time?
Yes.
Or are you kind of letting them feel it out given that you're still only at the 3-month mark?
No. So man, remember they get to practice at 6 times, right? 2 to 6 reps they can practice.
Yeah.
And so, but when I actually measure that, I do make them stick it for gyms because right off the bat, I want them to be solid.
Okay.
I'd much rather them jump 2 inches and be super solid than jump 8 inches and not be able to stick it well, right? Remember, most people re-tear it not on the takeoff or in the air. It's when they land on it. So I actually care more about them sticking it because it's what can they control, right? And early on, what do they have confidence in? Good. Okay. So in these later stages, right? So now we'd say, hey, we're working on jumping, we're working on running, we're working on hopping stuff. So we want to make sure at this point, do they have good mobility? The answer is they should, right? They should have 95 to 100% of their range. They should have full extension. They don't need to have all of their knee hyperextension compared to the other side, but they need to have the ability to lock their knee out. So they should have at least 2 degrees of hyperextension. If the other side gets to 4, we can strive for 4. If the other side gets 15 hyperextension, we probably should not push that knee to 15. I think the study says 8 degrees is kind of like where you start to stress the ACL, 8 degrees of hyperextension. But they need to be able to have some hyperextension, right? But at this point, they should, right? If we did it correctly, it meant early on, they were working a lot of mobility as well. What do you think is one of the reasons why someone coming in doesn't have mobility at this 5-month mark? What do you think? Because I'll be honest with you. All the studies say they should have full extension, they should have full flexion, but I find myself, I'm still working on mobility with some of these people at, 5-6 months out.
Anthony says Cyclops lesion.
Okay. So yeah, so there are people that have that scar tissue, and that's something you can identify pretty quickly. Like if you're at like 5 weeks out, 6 weeks out, and their extension really isn't changing, right? They're lacking 12 and they're coming in, now it's 9, and then it's back to 11, and then you crank on it and you get it to 9. Like, and there's like, hey, you know what? There's something that's not sense. Get them to orthopedics pretty quickly. Cause yeah, they may need to just take out some of that scar tissue. So that's a good one. What else? How about in the person that, they're lacking 3 degrees, 4 degrees of extension, and maybe they're lacking 5 degrees of flexion. So not crazy amounts, but it's not 100% yet.
There could have been some lack of mobility before the injury, and that's one of the reasons why they had the injury.
True. Oh, touche. Good. Yeah, there could be either prior to the injury or after the injury, before they had surgery. Let's say there was a meniscus involvement, right? And so they never gained full extension. And so now it's been 9 months, even though they're only 5 months out, maybe it's been 9 months since they had it. The nice thing is most of the people have ACL pretty young. They should regain all their mobility, right? Now, if this was a 50-year-old guy that somebody did a ACL reconstruction on, maybe that person may not get it all back because of the arthritic changes. There's bony changes. I can't stretch bone, right? But most of our high schoolers, college, 20s and 30s should be able to get full range. I would say clinically, people don't enjoy it, right? People would much rather do squats and strengthen and work out and be able to jump and jog and stuff. That's what people do. People don't want to sit there and stretch their knee and have it hurt and lay on their back with a weight on the back of their ankle or get on there trying to stretch their knee in the flexion. People find it boring, right? And people find it painful. So there's really not this desire to really push it. versus if they're squatting, and just like probably a lot of us do now, and we have a weight on and we're like, oh, if I really work on, I want to be able to increase my squat by 20 pounds, like you kind of strive for that. So we have to figure out ways to motivate people, right? And so one of the ways I do it is actually I hold running hostage, right? I tell them like, oh, you can't run till your knee gets straight. And that's what they really want to do. They always ask, hey, can I run yet? When can I run? When can I run? Let's check your knee. Is it straight? Nope, not straight. Nope, can't run yet. Right. So I kind of sometimes I'll use what they want to get to as a hostage to force them to get better mobility. So again, that's one. They should have good mobility. Exercise technique. At this part out, you should have been drilling into them, right? No femoral adduction, internal rotation. The knee doesn't go too far past the toes. They get a good hip hinge. Their trunk doesn't deviate laterally, right? At this point, 5 months in, they should have good technique. So when you start doing these higher level stuff, everything's on point, right? We've been working on strength, power, like stiff stuff. You've kind of been working on that. And then work capacity. Can they handle an hour of working out? Can they handle where they jog for 30 minutes on and off based on where they are in the protocol, as well as do squats and lunges and double limb jumps? Like, have they built up enough capacity where their knee can handle 60 minutes of stuff, right? So that's kind of what we're working towards. If they have all that stuff, great. We can kind of progress to some of these higher level stuff still. Right. So this is where we return to sport, right? So if they're going to return to these functional tests and training, we want 90% or greater on quads, right? So there's a study that said, what does that look like functionally, clinically? And it was 22 straight, so 22 in a row, single limb sit to stands. And what they had them do is they actually measured the table height to make it pretty systematic across. The knee angle had to be at 90 degrees, right? They had their hands behind their back, right? And they had a wall where they couldn't lean back against it. So there's like a foam roll behind them. So if you guys can see me, let's see if I put this on there, right? So if my hands are behind my back, I'm kind of leaning forward. Every time I sit down, I can't lean back for momentum. So it's one leg here and be able to go up and down 22 times, right? The group that was able to do that kind of correlated to this 90% as well as a decreased risk of re-tear once they were discharged out to the clinic. So I go, oh, that's pretty cool. So I can use this MMT test, but also this functional test. They should be 90% in all their hop tests, 90% on their KOS, so like a knee outcome score, and then 90% on another knee outcome score, right? All right. So if you look at it though, one of these tests is for strength. One is for the ability to jump far, so produce power, stick a landing. And two of them are how they feel about their knee and any limitations they have, right? So I kind of added, it's not part of any research thing, but do they pass the eye test? There's some people who, yeah, they're 95% strength and yeah, they're doing 22 reps and they technically jump as far, but man, they just don't look as solid on that leg as they do on the other leg. So part of it is like, there's this built-in, not necessarily just quantity, but quality of how much quality do they have? Because again, and it's hard to study that in research. It's hard to study because there's so much variation to do that. So that's kind of my own little added thing. Good. Okay. Plyometrics. So as we move along, all right. So the whole goal of this is can they control anything coming down, right? So this deceleration, and then quickly turn it around into acceleration. Nice thing is it improves strength, right? If you want to be sore, if your patient doesn't feel DOMS and they're able to start jumping and doing plyos, it's a great way to get this quick stretch of the muscles and create soreness, right? They do have guidelines, right? So based on how big someone is, how much they weigh, I would take that with a grain of salt based on who you're working with, right? So if you have a professional athlete who's 6'5", a lot of them are going to weigh over 220, but they're going to be in great shape and their BMI is really low, go for it. So it's more for the recreational athlete that has a BMI over a certain amount, right? You're not doing them on back-to-back days. This shouldn't be the last thing you do, right? If they've been working out and they're fatigued, this is not what you should be doing last. And then they should warm up, right? You don't want to create these tendinitises or these strains of other issues. Good. So if you work from plyometrics, step one is jumping to a box. Why do you guys think it's important to jump to a box versus from a box?
Less stress on the knee jumping up.
Yeah. Yeah. They don't have to, right? The idea of what goes up must come down, right? And the farther it has to go down, the more stress it gathers, right? The more speed, velocity. So if you jump up and you're only going down a third of the way, right? Or a quarter of the way, you don't have to absorb nearly as much shock. That's one. But two, also, it really facilitates knee bending, right? If you have someone jump up on a box, a lot of times they're landing in this mini squat, right? They're not landing straight up and down. So that's kind of a nice thing as well. So it kind of facilitates this less stress, but also facilitates how we want them to land, right? And as Mr. Deeker said, right, you're starting with two legs. So two legs to two legs, and then two legs to landing on one leg, and then go from one leg to the opposite leg, and then finally, same leg to same leg, right? So you kind of have this progression, and this progression may be something you work through over the course of 2 months, right? Jumping to a box. And you can always just make the box higher and higher and higher to make them have to jump higher. Jumping from the box, right? Now when they jump down, it's even more gravity that they're gathering speed, right? And then you're trying to work on, and this is where you can really work on, as soon as they land, they jump back up. So kind of this bottom picture here where you're really trying to work on, can they quickly turn around that force and explode? Okay. Always start with forward, right? And then the idea is to progress to diagonal and lateral. So as soon as they land from the box, they're jumping lateral, would be progressions. Good. Here's some of your parameters where they're starting out when they first start training on it, right? 60 ground touches would be ideal. There's a lot of rest time if you're doing true plyometrics, right? Because when you do true plyometrics, you should be going hard out as everything as you can, right? So you have these long rest breaks. If it's submaximal, right, where they're able to go 30 seconds, right? I tell people, think of a 100-yard dash, right? Those people are running it, right, 10 to 12 seconds, right? If you're really elite, these 10 seconds, they're not running that again a minute later, right? Because they gave everything they had. So think of that. If it looks like your patient is given everything they got, give them time to rest. Otherwise, you don't need to let them rest as long, right? 3 to 4 exercises, 2 to 4 sets, 6 to 15 reps. Right? Good. And here are just some examples of if you're trying to work on explosive strength. Here's some things that you kind of can work on different things if that's the category they're trying to build on. Versus, let's go into agility. Right? Any questions on kind of the jumping or the hopping, the plyometric stuff?
Nothing in the chat.
Yes. Okay. Nice. All right. How are we doing? So if we kind of move on to agility, so we've now been working on plyometrics. We want to be able to change direction, right? The nice thing is it's very sports specific, so it's required a lot in sports. This is mostly where your non-contact tears occur, right? Someone's running and then they have a quick change of direction. Their foot went one way, their knee went the other way, their body went the other way, and then they tear it. So we want to train people to be able to load it properly and then push off, right? So some of the precursors is they should be able to do like these sliders or skaters where their legs are going in multiple directions and they have really good trunk control, femur control. They should be able to load that limb jumping into different directions and being able to stick it. So if I jump forward, can I stick it? If I jump lateral, can I stick it? Because if they can't even stick a single motion, how are they going to be able to change directions quickly from this position that they can't even stick well? So that's kind of why this single limb hopping comes before agility. Good. So acceleration would be kind of like you're running forward. Deceleration, kind of you're slowing down, stopping. So based on where do they have issues on, right? It's when they're pushing out of it, they have issues. It's when they're slowing down, they have issues. You can work on them together. So a lot of these like V cuts, or you break it down and say, hey, you know what, your deceleration, they call this the breakdown. So if I'm running really hard and I'm going to stop, I should have couple of these breakdown steps. So it should be like 1, 2, 3, like you may hear the squeaking shoes, That's okay. That's kind of normal. People need to slow it down. If someone takes 5 or 6 small steps to slow down, all right, we need to start working on their eccentric strength. They got to be able to do that a little bit quicker. All right, so they're not ready for agility yet. Let's back them off and work on some of our eccentric strength more. Right? After they have some good training that they know exactly what they're going to do, so whether it's lateral cuts, whether it's forward and backwards cuts, right? Acceleration, deceleration, start adding cognitive components, right? So start having them change direction without them knowing. So a lot of time they're following you, like they call that the mirror drill, where you're kind of going left or right and they're following you. You're going forward and backwards and they're kind of playing defense. It can be they have to change directions when you make a noise, when you clap. They have to track a ball. So they're kind of going one way and then you throw the ball in the air and they have to change directions to go get it. All right, so you have all these different things that you can do. And again, people enjoy doing that. Like if you have a bunch of guys working out in the gym, people enjoy doing a lot of these sports stuff. Are they ready for it is the big thing, right? They all think they're ready for it. We got to make sure that they actually are ready for it. Okay. And here are some, I know this is a busy slide, but I tried to fit in some of the big ones that I like to use in the clinic. And these are like some of your agility tests. Realize there are a lot more than that. But the nice thing about these is that you can do them in like a limited space, right? So your T-test is where they're running forward 10 yards, side shuffle left, side shuffle right, alternate, and then back pedal down, right? So it's mostly used kind of for basketball players to be able to do different motions, and they have norms on what you need to get in order to be discharged for PT, right? So I like that. People like that. Patients like that. They like a goal of what they need to work towards. Your pro agility test, where you face one where you run one way 5 yards, turn around, run all the way across 10 yards, and then back to the middle. And it's, again, this is a quick change of direction. They touch the line. And again, you have these times. So 4.6 for like your super elite, under 5 seconds still though should still be for your high school athlete, recreational athlete. Single limb square jumps. So you're jumping in, out, all 4 ways, and you're doing 5 cycles of that. The goal is they should be able to do that in 15 seconds. So if you think 1 cycle in, out, that's 8 jumps, right? They should be doing 5 of them. So that's 40 jumps that they should be doing in 15 seconds for return to sport. Hexagon, your 6 sides. It's kind of very similar. In, out, in, out, in, out. This is 2 feet, and they're just doing like a clock, in and out, doing full round. They should be able to do that in 12 to 13 seconds. And then a little bit longer one, which is kind of it takes almost 2 minutes to do, which is kind of nice, but it incorporates all these different cuts and slides and diagonal motions. It's kind of a little confusing. You have to walk them through what to do. But the nice thing is it takes into account 90-degree cuts, 120-degree cuts, 180-degree cuts, karaoke, side shuffles, back pedals. And it has a time for what people should be able to do. A little bit of a variance based on what position they play. Obviously, offensive linemen aren't going to be nearly as quick and fast as maybe your wide receiver who has a little bit more little stamina. Good. Okay. Any questions about kind of our agility? We're getting close to the end. So thanks for hanging in there, guys. So the idea is if someone's going back to soccer, someone's going back to basketball, even here they have stuff now on return to hockey. So on ice, return to hockey, right? This is kind of where as a PT, based on where you work, you kind of start to then, if they are on a team, it's great because they can start to go to practice and work with some of the sports trainers or start working with the coach and be like, hey, there's no contact, there's no scrimmaging, but you can start to do some of the drills because it's actually more sports specific, right? JOSPT put out articles that kind of give suggestions for on-field, on-court, on ice, some things to work on that kind of mimics what they would do in a game. So it's kind of nice. The hard thing is it takes more room, but this is where, again, when they go out and they practice on a field, I'll give my athlete that's like, hey, you are 8 months out. You need to be doing soccer stuff on a field. You can print out, it has pictures on there and you can give it to them. Be like, hey, here you go work on some of these drills on your own. Maybe a 50%. If you feel good, then move up to 75% effort. But it's nice because it puts them in their element. Right. Good. And then here's one that just came out. So June 30th of 2020, it was this big consensus on ACL where a bunch of people got together. You see all those athletes right? Or all these authors, Kevin Wilk and stuff. Tim Hewitt does a lot of research as well on ACL. And they kind of pretty much came up with the idea that, people are returning too soon and people are not returning with the amount of quality of tests that they should, and people are re-tearing too often. It's like, okay, you kind of summed up what we know. But then the nice thing they said is, if people can find if people pass these functional tests, so all those agility tests I talked about, all of your hop tests, if people are passing all of those, it corresponds well to a lower risk. And again, I say lower because there is no such thing as no risk, but it does have good carryover. So I'd say we need to be using functional tests, not just, hey, my knee feels good, I'm running, I'm jumping, I don't have any pain, they have good range of motion. It's more than just that if we're going to return them to sport. If someone's only going to return back to walking and they want to do yoga and they like to do the elliptical at the gym, sure, maybe we don't need to keep them for 9 months, 10 months, right? Good. As you run through the testing, right, the algorithm says, hey, I'm able to do full speed agility training without pain or apprehension. They're going to 100%. The answer is no, keep working on it. If the answer is yes, okay, now you can start doing your sports stuff. But again, no other player is doing it with you. You are unopposed, right? It's just you. If the answer is yes, I can do it, I've been practicing 100%, great. Move on to one-on-one. If not, keep working on it. So it's kind of seems like it'd be common sense, but sometimes when things are written out for us to see, it actually has a little bit more meaning. It's like, okay, I can show them and be like, hey, this is where you are. We got to keep working on this. It gives you some guidelines as well, because sometimes I feel this way. Patient's been coming, been working on the same thing for 3-4 weeks. You feel like, oh, I got to progress this guy. I got to progress this guy. He's getting bored. He's starting to lose some of his compliance. I need to keep him engaged. Let's make things harder. Let's ramp it up. But then like, hey, you know what? No, let's test it. He's not ready for it. Stick with it. Find other ways to make it a little more challenging without putting him into a whole new category. Good. All right. Lastly, and again, I'm going to email this out to you guys. You guys will all get an email with this PowerPoint. So we'll have all this. And here's just kind of like I took a lot of the studies that have norms to it and kind of put it on one big form. I carry this on my clipboard at work. That way, as I'm going through stuff, I kind of I know how to remember how long they should be. The other good thing is, if I'm always comparing, maybe I'll ask you guys this, if a lot of these return to sport are compared to the other leg, what are some of the issues you might find in that? Like, hey, my quad has to be 90% compared to the other leg. I should be able to jump 90% compared to the other leg. Do you guys have any issues with that?
Their contralateral lower extremity is not as strong as before the injury.
Yeah, exactly. Maybe the other leg isn't as strong, right? So now this 90%, it's not even 90% of the other leg, it's 90% of the other weaker leg, possibly. Okay, what else? Hopefully, oh, go ahead, sorry.
Handedness will contribute to strength differences.
What was that first part? Sorry, I missed it.
Handedness, so left or right footed or left or right leg.
Totally, yeah. If I'm a basketball player and I'm right-handed, I jump off my left leg a lot more, right? My left leg should be more than my right leg. But if that's the leg I tore, right? Okay, so maybe there's a bigger difference than you think. So that's good. They've actually done studies to look at what sport you play and even what level. Are you varsity, junior varsity, elite college, and like what are the norms for that? Which is kind of part of this scale, actually, college. But the other thing is, you've tested it how many times, right? By the time they're getting close to discharge, 8 months out, 9 months out, you've been testing it for 2 months now, 3 months now. You've told them at some point, hey man, in order to get discharged, you get 90%, keep working. Does that incentivize them to jump further or shorter on their non-surgical leg?
Shorter.
Yeah, especially that, 16, 17-year-old high school kid going into his senior year, right? Doesn't have knee pain. He's pretty confident. Those aren't the people that are scared. they're not worried about retears, they're not worried about anything in the world at that age, right? They're going to start sandbagging it a little bit, right? So I want to always make sure that I don't necessarily tell them this 90% early on, because I want to see them jump as far as they can on the other leg and get like a norm for that. And then as we get closer, if that norm starts to sink down a little bit, right? Hey, you know what? At 5 months, the first time we tested this, right, your triple hop was 14 feet. Now your triple hop's only 12 feet. You think you've gotten 2 feet weaker, or are you trying a little bit less, right? So the nice thing about this is it gives me norms for not only some of these time stuff, but someone doing a single limb triple hop or a single limb crossover hop, like there's norms on what they should be able to do. And again, it's a little bias. Not everyone's going to jump that, but it should be in the ballpark, I would hope, right? If someone's going to just do a single hop for distance, right? 70 inches, 50 inches, 75, 58, right? Great. You should be close to that. So that way they're not just sandbagging. So that's good. All right. And lastly, if we think about outcome measures, right? Here are some good outcome measures. A lot of the research uses those first two, right? The knee injury and osteoarthritis score, your COOS. The COOS has different sections. One of the sections is on sport. And they also use this International D documentation, the IKDC. So you should be 90% for the COOS, and I think 92% for the IKDC for return to sport. And so those are part of the criteria to return to sport with a less risk, right? Partly it tells you how well their knee is functioning. Partly it tells you how confident they are, right? And then I threw in kind of this Tampa scale for kinesiophobia because, again, 20% of people don't return to sport because of the psychological fear of re-tears. It would be nice if you pick that up at month 5 or 6, so that way those last 3 months together, you're working on stuff to make them less fearful versus giving it to them at month 9, ready to go. And then all of a sudden you realize, oh my goodness, you're quite fearful of re-tearing this knee. We're going to hang on to you because if I let you go now, you're probably not going to go back to your sport. Right? All right, I think this is so a couple more slides. So association between passing the sport criteria and a secondary and a re-risk, right, is what they looked at. And with the return to play, if you're meeting these 6 criteria, so less than 10% quad strength, 90% in all your tests, you completed your on-field rehab program, meaning those things about soccer, basketball. I did my agility test 100%. I did my, I went to then unopposed. I then went to one-on-one. That's kind of that rehab stuff, right? That is this right here, right? They went through some type of paradigm of that, right? As well as their T-test under 11.6, that leads 4 times lower risk injury. That's good. Anything we can do to lower the risk is better, right? Another one looked at those that returned to level 1 sport, so high level sport, had 4 times higher risk of re-injury than those that didn't. So that feeds into the just more opportunities to tear. People that are going back to a higher level sport have more opportunities to tear based on practice time, game time. Re-injury rates were reduced by 51% for each month. Return to sport was delayed until 9 months. So if you're going back at 6 months, 7 months, 8 months, you are significantly higher than 9 months. So even if they look really good, right, I have a conversation with the orthopedic surgeon, with the patient. If they're under 18, it's having a conversation with the patient's mom about you are passing everything. You are 8 months out. I would, however, wait another month would be my recommendation to you. But again, patients don't necessarily always listen because some of them are, hey, I only have 2 months of the season left. I'm trying to get a college scholarship. Okay, understand the risks. Decision's yours. Okay. People that failed this criteria, 38% re-tore. So no more than you're already at risk to re-tear, but now it's higher than what's typical. And so can we wait longer than 6 months? Can we get to 9 months is the goal, right? Do you guys know what that number turns to if it's a re-tear? Let's say they've torn it once and now they're on their second tear. What is the return to sport cut off at that point?
Nine months?
No, a year. So if it's a re-tear, right? The bone plug takes longer. The ligament isn't as stable because they've already drilled into the knee at one other point. So now you have to wait a year, right? So instead of 9 months, it's 1 year. Good. Good. Athlete, just a new study that just came out last year that talks about a 7-time injury rate if you go before 9 months. So again, they've redone it and found out like, hey, really, people shouldn't be going back to sport. And this is something where I say this has changed my practice probably in the last 5 years. I'd say in the first 5 years, it was, man, the goal is to pass everything, right? Make them strong, make them kick their butt. And if they're good to go at 6 months, why wait 9 months, right? They're passing everything, they're solid. Now I've definitely changed my tune a little bit where like, hey, even if they're doing great, I would still recommend waiting, because if you do re-tear it, it's a much bigger issue. All right. So some of the physical agents, and if I'm now going to switch back to, right, PhysioU again. So we've kind of looked through some of these associated impairments, we'll call them. If we go back to the physical exam interventions, that's pretty much what we just got done talking about. So you have all of your mobility work if you need to, your coordination. So you have all these different exercises, strengthening, balance and proprioception, right? You have all your hop testing, right? Nice things, you have all your norms and videos for what they are. But if we continue under interventions, we go to modalities, right? You have different modalities to kind of help with control pain, control swelling. It's part of it. Physical education, right? This is where we have all the different things that we can email out to a patient, right? So if I go return to sport, all right, you can then just kind of click it. This is a JSPT perspective. So it takes you to this return to sport, and it pretty much sums up a lot of what I just said tonight that you can email to a patient to get them to really try to use that way, to work on some of the things in preparation for discharge. If I go to the special tests, if I go to patient education, click on knee, right? ACL surgery, right? Here's a 3-minute read that talks about, again, it's a nice thing written for patients. So it's not like therapist lingo, it's patient lingo. Now you can just click here, send them an email if you have any patients that are currently going through ACL rehab, right? And it talks about a lot of the evidence that I brought up, and then give some of the common exercises that they can work on in some of these later stages. All right, so there's your link. Good. All right, so that is ACL in a nutshell. What do I do? 1:27, man, a little bit longer. Sorry, guys. I'm going to stop sharing screen for a second. All right, nice. So in 2 weeks, we'll do it again, but we'll pick a new topic. I think we're doing low back pain with leg pain. So we'll talk about the difference between radiating pain and related leg pain with that. Yeah, thanks guys for hanging out and listening. Again, I will get you guys that PowerPoint. Anybody that registered, we have your email address, and then we'll put it in a PDF, send it to you. Anybody have any kind of questions that we did not, we didn't answer in the chat? We'll blame Cameron and Chris on that. Or if you guys have any ACL patients that you want to talk about or anything, I'm more than welcome to stay for a couple minutes.
One from Gabriella, and she wants to know if a patient reports a fall and injury to their knee, at what point would it be okay to do special tests and not hurt the graft?
Oh, so that's an awesome question, because you think about if you're going to do like an anterior drawer, or you're going to do like a Lockman's test, right? We always want to think, are we pulling on that graft? But think about when they go back to see the orthopedists, they go back after 2 weeks a lot of times for knee instability, ACL. They go back after 2 weeks a lot of times for like take out stitches or staples or whatever they had in there. They take them out, and they don't really test anything. They let it go. But at that 6-week visit, sometimes it's 8 weeks, a lot of times the orthopedist is hooking up a KT 1000 or KT 1000, and they're testing it. They're doing it, and they're like, hey, this should be solid at 8 weeks, right? So I would say at 8 weeks, it's pretty safe to do it. Now, does that mean I would pull as hard as I can? No, I probably wouldn't. But I would still definitely look at an anterior drawer Lockman if someone is telling me that they fell and that. If the knee is super swollen where it's early on, you're really not going to be able to tell anyways, right? Because the skin is so thick and stretched out and tight that it's hard to even feel excursion. So it may not be the best. So I would say if someone fell, they complain of an instability in their knee, and you're even thinking it's a possibility, I'd probably say, hey, go get it checked out. If it's a possibility. But if it's later on, let's say they're at 5 months out and they tripped or something and they fell, right? I have no problem putting them down, looking at it, and see. So I would say sometime early on in your rehab, you should definitely check it. So at that 8-week mark, check it. So you have, and then try to write a note in your notes to remember about how it feels compared to the other side. So in my note, I would write, right, 10%, 20%, 30% looser than uninvolved or stiffer than uninvolved. Because let's say they fall at 6 months out and you check it, it's never going to feel the same as the other side. They had surgery on it. So you want to know like, oh man, that is loose, but maybe that's how it was already before they fell. So it's nice to have like a reference point to see, because there's people where I've sent back to orthopedics, I've retested it. They said they had a fall. I retested it. It was loose. It's like, man, that's loose. I went to orthopedics. I had an MRI and like, no, it's not torn. It's good. I'm like, man, so your graft just stretched out a little bit, or that's just how it was. It's like, okay, we'll run with it. But good question. You can take credit for that one, Cameron, or is that somebody else?
Well, that was by Gabriella Schmidt.
Oh, nice question, Gabriella.
I have a quick question. Do you ever have experience using the Vail sports test?
No, not really. It wasn't part of like our fellowship stuff that I went through. And it wasn't part of like the stuff I've taught at CSM. So I know a little bit about them, but I don't use them. I think partly because it wasn't what I was trained in. Is that your question or is that somebody's?
That was just my question.
No. Is that something?
It's something we've used with a couple of the return to sport athletes at the very end, mostly just to see their endurance. I was just wondering if it's a newer test, because it's something that we haven't in school also addressed.
No, I think when we were doing like our VO2 stuff, like get your boost. I've heard of it. I don't know. I'm trying to think of where, but it's not anything I use in the clinic. No.
Okay.
Is that Modus that you've used it at?
Yeah, it's a pretty brutal test, because it's in terms of just endurance, and people pretty much go to failure because you're doing stuff for like hopping for like 3 minutes, or doing resistant stuff for 3 minutes, and really seeing kind of any movement faults. So we've only done it once on a football athlete, because it does take some time. But I was just wondering, if there's something kind of across the board.
That may be something to consider to make it official. I would say I definitely, when I check noise hops test, I definitely check them at different parts. So sometimes it may be in the beginning, sometimes it may be, okay, we're going to do uphill sprints on the treadmill and we're doing intervals. And then you're going to do your jump squats, and now you're tired. Now let's check noise hops test. Okay. Right. So I pick different times just purposely to say, hey, let's look at it when you're tired. Let's look at it when you're fresh. And surprisingly, sometimes people jump further when they're tired, just because all their muscles are so primed, ready to go. Neuromuscular control is totally ready. Even though they're tired, they just have like a little bit more explosion, right?
Yeah.
So maybe they're not tired enough. They're just warmed up. Okay, keep going. More sprints, dude. So I'll tell them.
Hey, Marshall, I had a question for you.
Yes.
I apologize if you already covered this earlier in the class, but when it comes to ACL and also when it comes to re-injury, and the practices you have and the doctors you work with, are they using cadaver, Achilles heel, patella tendon, hamstring? When and how would you recommend that? I'm working mostly with adults, fire police, who are not as, some of them are sporty, some of them are not, some of them are overweight, some are not. What would you recommend and why? What is the literature saying about Achilles tendon still?
Well, I mean, if you're using a cadaver graft, that's definitely less used now, unless they've retorn it. It's like their second tear and they need to, just because the rates of re-tear are significantly higher and the cost is significantly higher. So at least in the orthopedics where I work and the research, they've tried to use a lot more of like, pay that person's graft, right? To use an autograft. So that's kind of most, as far as if they do decide to use like a cadaver graft, I'm not too familiar about which graft has better outcomes or not, as far as whether it be an Achilles or this or that. I just know that using a cadaver graft in general has more re-tears than in autograft. Does that kind of answer you a little bit?
Where the doctors I usually send my people to,
Yep.
they usually been using the cadaver Achilles tendon.
Okay.
I haven't had any post tears. I've had some like patellofemoral pain, but I also noticed those who chooses to use hamstring tendon for ACL, higher more level of patellofemoral pain on the 3rd month of rehab.
The people that have the hamstring graft have more pain?
Yes.
Less pain. Oh, interesting.
More inflammation.
Okay, interesting.
That's what we noticed. That's what I've noticed.
Yeah.
And
I would
extremely tight IT bands as well.
Yeah, I would agree. Definitely, they all kind of tend to compensate with trying to use any other muscle but their quad at times. So they'll use other muscles that cross the knee and help extend the knee, like your TFL crosses IT band. So I would say, yeah, I mean, that may be maybe based on the population you work with, right? You work with a lot of like law enforcement and firefighters, you said. And so maybe are they jumping as much to where they're not getting, so maybe that's why they're doing a lot more loading versus the athletes. And some of the research, it shows that with the patellar tendon, you're more likely to have knee pain, anterior knee pain, just because of the fact that that extensor mechanism was disrupted at some point.
Most of the time, the mechanism of injury for firefighters, unstable surfaces, walking at nighttime on a emergency where they cannot see, or going to people's homes for first aid. They trip on the toilet, they trip on the carpet. And for cops, it's usually fights that with the sheriffs that I work with, they get in the middle of a fight between inmates, the knee gets cramped in the middle of the leg, body, and there goes the ACL, there goes L4, L5. But that's kind of situations where I get the most instability. That's why before I let them go, I make sure that proprioception training is very high and instabilities are really high, not just with the bilateral legs, but also with the cross with upper extremity, you know?
Totally, yeah.
So things I learned from Gary Gray on the things I attended.
Functional stuff.
A lot of functional training, and because it's instability, I wasn't paying attention, or the sidewalk of the curve, or they trip, you know, when you're working at structure fire. Right now I'm working with a lot of firemen coming back from Northern California, and it was going up and down the hills carrying hoses. Those who've had ACLs before, I noticed their hamstring or Achilles tendinitis or patellar tendinitis was the biggest complaint.
Yeah, I can totally see that. And that may be where, based on that patient population, you may not value some of the noise hop tests nearly as much, because those are like return to sport. You may value, all right, my 4-cone test, my cane tests, all these ones that look more at change of direction, unstable surfaces, loading, and they have norms for all that, but it's not necessarily leaving the ground and landing as much as is, hey, I'm stable on one surface, I'm stable. And so there's other tests out there that may be more valuable for your patient population to be like, hey, are you safe? Let's look at your proprioception on your uninvolved leg with your eyes closed, you know, being able to touch a surface at 6 inches away, 8 inches away, and 10 inches away. Now let's do it on your involved leg. How far can you go? I mean, that may be more valuable based on what they're going back to, right?
There's actually a physical therapist was hired by the Denver Fire Department. He's an
Casey.
specific alumni.
Yeah, Casey Stoneberger.
Yes, I haven't met him yet, but I've been in contact with him. He was supposed to have a conference April, and I was supposed to go there and learn from him and everything. He was hosting people from, like myself, from LA City, LA County, Ventura. And yeah, he has an amazing job. He's done tremendous, has shown degrees of injury prevention and rehabilitation within the fire. He saved a lot of money to the department just from prevention of injuries. So he's done a good job. And he said, yeah, I'm a specific alumni. So,
Casey, I've met him. I mean, we went to school he was a year below me. But then we kind of met up at CSM a couple times, and we've talked about some of that stuff. And I watched him talk last year. So we've kind of, I wouldn't say we're buddies, but we've had conversations before, and anytime we're around, because we went to the same school and I know him from school a little bit. Good guy.
Yeah, I want to learn from him. So I have a lot of issues here with thanks so much for your help and information. Thank you.
Hey, no problem. Steven, my pleasure, man.
Quick question for Dr. Lemoyne.
Yeah, what's going on, MJ?
Sorry, it's not related to ACL, but it's related to the abdominal. It's either your MMT or your coordination testing, where I believe you have 5 grades. Like, can you lift up 1 foot at a time? Can you slide 1 foot out, and then can you hover it? And then same thing with double limb.
Yep.
Are there MMT grades associated with those grades of like test?
No, not MMT as far as manual muscle tests. Those are performance grades. So they're graded on level of difficulty. But there's studies that have looked at those using EMG that show like the higher the level is, the more EMG is required of the muscle. So you could be like, so it doesn't correlate to actual grade per se as much as it's a level based on, but it's not like your Asia scale like you would think of how much force can they handle. Does that answer it? So it's not grades of the levels, but it is performance levels of what they can handle.
Yes, thank you.
Okay, yeah. I would say the other ones I would tend to use would be like your side planks for AC. If it is ACL, it's like, right, side plank times are a big one, more so than like a front plank, right? Because you want lateral stability. Are those equal side to side? Can they get to that 45 seconds? Can they get to that 1 minute mark as like a cutoff for safer return to sport?
What would you say, sorry, going off your side plank grading, if they say they're lacking the ability to hold it because of maybe a shoulder weakness or instability?
Yeah.
I mean, I've had a patient before where they're like, it really hurts my shoulder when I'm in this position, and I don't feel it in my abs or my like glute med.
Okay.
Is that an accurate test still?
No, because if they're stopping because of their shoulder. So I know like McGill does stuff where like he loads up the shoulder with the other hand to help support it and stuff like that. Otherwise, it may become choosing like lateral medicine ball throws. Like how far can you throw the medicine ball one way versus the other way, where you're still recruiting a lot of your obliques. And now it becomes a performance test instead of a time test. It's a, hey, how far can you throw it one way? How far can you throw it the other way? Would be that. But I would say if they can't do a side plank because it hurts their shoulder, maybe we need to start to build in some type of shoulder rehab in there. All right, while you're doing your lunges, start doing some rotator cuff or scap stuff at the same time.
Right.
Yeah.
Awesome. Thank you.
Yeah, of course. Cool.
Dr. Lemoyne, so I know a lot of the hop tests, the noise hop tests are in the sagittal plane besides the crossover hop.
Yep.
Do any lateral hop tests, and why do you think there are no lateral hop tests within that those categories?
Yeah, I don't know why there's no hop tests in the like the noise hop tests. I don't know why there's no lateral one. Sorry, not sure why there isn't lateral in the noise hop. The lateral ones that are included would be, a lot of them are like your timed ones, so change of direction. So your hexagon test, your four square test, like those are all lateral hopping on one leg, but it's not a distance. It's not a distance measure. So I don't know of any tests that measure distance of a lateral hop as far as like a cutoff score. I'm not aware of any of them. However, I do use lateral hopping a lot in like their training. So lateral hopping over cones or over hurdles in the ladder, right? Using ladder stuff because that's common in sport, right? So I use it all for rehab, but I'm not sure of any tests. And maybe that's one of my fails. Like I don't actually measure it as far as how far can you jump to the right, how far can you jump to the left, and compare it side to side. So that's a good point. The Cameron test for lateral hopping distance. Validate that. PhD program. Let's do it.
Most of those asymmetries are in the transverse or frontal plane besides the knee flexor strength you mentioned in the beginning.
Yeah, but they're not necessarily it's not necessarily like force produced laterally, it's just quality. So the only one that really is like a force production is the strength in that sagittal plane. And that's why that like single limb hop has the highest correlation to quad strength. So maybe that's why those have been, because like, hey, people that tested weaker couldn't jump as far, right? So it's, and that's kind of one of the downsides of the noise hop is it doesn't take into effect quality. It's just quantity.
Thank you.
Yep. Good. All right. Are we going to call it, guys? I think so. All right. Cool, guys. Thanks for hanging out. I know it was ended up being a long night. Hopefully you guys learned something that you can use with your next patient. Thanks for all joining, guys, and we will get you that PowerPoint. All right. See you guys in 2 weeks.
Awesome. See you guys. Thanks for joining.
Thank you, Cameron. Thank you, Chris, for your guys' work.